Denver, one more time.
Now I'm ready. Action.
This is Chadi Alraies, Denver, Colorado. This is CVI 2019. With me is Dr. Ryan Mader. He's the Section Chief of Cardiology, Interventional Cardiology, and he's the Director of a Cath Lab at Spectrum Health. Welcome, Ryan.
Thank you very much.
You gave a phenomenal talk about radiation safety, which is a very important topic to the interventionists, the risk of brain cancer, or cancer in general, and cataract, and what else. Can you please teach us a few tips about it?
Yeah, I think, unfortunately, too few interventional cardiologists get interested in radiation exposure until it's too late. And the way that I got interested in kind of the risks of radiation was as a fellow. Two of our interventionalist attendings actually developed cancer. And, you could actually feel a difference in cath lab behaviors the day prior to the diagnosis versus the day after. And I think it's a much wiser approach to be more proactive, particularly young, when we're younger in our careers, as opposed to waiting until we've been in the cath for several decades before we really start to pay attention to it.
Right. So what is you have done a lot of research in that area. Mm-hmm. What is your experience of kind of practice that cardiologists doing right now that expose them the most to radiation?
Yeah, so really two principal risks for interventionalists. One is related to wearing the heavy lead garments that interventionalists conventionally wear, and the concern that creates is the risk of orthopedic injuries. And so orthopedic injuries are extremely common in the interventional community. Some of the data suggests at least half of interventionalists are going to have some sort of spinal problem during the course of their career. And we have technologies that have become available over the last several years that really allow you to get out of lead. And I think it's something that many of us have adopted as a way to try to prevent ourselves from developing these orthopedic injuries. The other major risks, of course, are related to radiation itself, and in particular for physicians, the stochastic effects, mainly the risk of cancer. But as you said, there's also evidence that interventionalists may be at about a threefold increased risk of premature cataracts compared to unexposed individuals. There's at least one paper that has shown that interventionalists may be at risk for premature atherosclerosis in the carotid arteries. And actually a very, very compelling paper published in 2017 in Circulation showing very, very compelling evidence that even a single procedure where we use fluoroscopy can result in a measurable amount of DNA damage for the operator.
Wow. So this is scary news to the interventionist. You mentioned about the physical burden and the spine injuries as well. I read a few literature suggesting some between cases you do certain exercises or certain posture or exercises during on off time to increase the core muscles and stuff. Is this something we should focus on?
Yeah, I don't know if there's a lot of evidence, scientific evidence that's helpful. I certainly have a lot of interventional colleagues that do a lot of core exercises hoping to prevent injuries. The approach that I've taken actually is to get out of lead completely. I wear lead now in the cath lab fewer than 10 cases per year. And the way that I do that is I've adopted using a suspended lead suit for every single case. And when you use the suspended lead suit, not only does it provide you additional radiation protection because the lead is thicker, but you're not bearing the weight of that lead. And so I hope that that's going to translate over time into less risk of orthopedic injury.
And is this lead mounted by the ceiling, or?
Yeah, there's two ways that those systems come. You can have it mounted directly to the ceiling in the cath lab. I think your degrees of freedom for movement is a little bit restricted when you have it that way. The other way is to get it a mobile unit that's attached to a boom arm. And I think your freedom to move around the cath lab is a little greater with the mobile unit.
Yeah. How about robots?
Yeah, so the robotic system for doing PCI is another thing that I've adopted in my practice to try to reduce my radiation exposure. And using real-time dosimeters where we can track our radiation exposure during the course of a case, we found in our lab when you're sitting in that cockpit doing the PCI, you essentially get zero radiation. And so, of course, you still get potential radiation during the diagnostic portion of the case, but when you're in the cockpit, the radiation is essentially zero.
So beside the cost, what is holding us from having robot in every lab?
Yeah, I think right now it's the cost of the robotic system and the capital purchase, and I think a lot of administrators, really are resistant to the idea of the purchase of a system like that. And so I think, unfortunately, that does, in a negative way, impact safety in the cath lab by not having administrators adopt these.
But there is no pitfalls or there is no steep learning curve in order to do the robotic procedure.
I think operators of our generation grew up playing video games, and so we spent much of our childhood staring at a screen, manipulating joysticks, and so it was a very natural transition for me into the cockpit with a series of controls.
Okay. All right, so as long as the staff equipped and taught, the equipment and stuff, no barrier to adopting this practice.
No, I don't think so. I think the learning curve, having gone through this, was actually bigger for our technologists, and they went from a situation where we were always at the table doing all of the exchanges to a situation where they were the ones suddenly doing exchanges, and I think that was a bigger learning curve for them. But they've gotten to the point in our lab where we have several of our techs that are very savvy with the robotic system that can do an exchange as fast as I can.
Few comments about remote PCI.
Yeah, so this is something that I've really had an interest in, and it involves adapting the existing robotic technology to try to reach people that are far away from us. And the impetus to do this in the coronary world is really, driven by the fact that 80% of the population in the United States lives outside of a 1-hour drive to a PCI-capable hospital. And of course, the place where that's most important is in the setting of a STEMI, where time is myocardium. And so, we've envisioned that we potentially could develop this robotic system where we could address this gap in PCI access, to places that have these geographic barriers that prevent people from getting to interventionalists quickly. I think the other interesting place where this may go is in the treatment of acute strokes. We think about geographic access being a problem for primary PCI in the setting of STEMI. That access issue actually pales in comparison to what we're facing right now for patients experiencing an acute stroke. And so I think it has the potential, if we can adapt the robotic system to treat acute strokes, that we could use it as a tool to deliver care.
Awesome. Well, thank you so much, Ryan, for your time.
Yeah, thank you.
It's very insightful. Radiation safety, robotics, remote PCI. This is great new science. Watch this video and others on CVI YouTube channel. This is Chadi Alraies from Denver, Colorado. Thanks, Ryan.
Yeah, thanks, Chadi. Thank you. Good to see you.